which will be held by Tehran University of Medical Sciences in association with APRAISE to Raise team. And at the beginning, I would like to express my sincere appreciation to you all for follow our program. And also, I would like to thank our lecturer. First of all, I would like to thank Dr. Sudeendra Prabhu for accepting our invitation to have a case presentation in this webinar, and also my colleague, Dr. Samira Derakhshan. She's my colleague in Oral Pathology Department of Tehran University of Medical Sciences. I think we have 1 minute to get started the first lecture, and I would like to ask Dr. Prabhu to turn on his webcam. Hello. Would you turn on your mic? I cannot hear you.
Hello,
sir.
How are you? Good morning. Is it a good morning there? Over there, what is the time right now, sir?
Yes. Good morning. But I think there is night in US because Dr. Nasser told us he kindly joined us in this webinar. Okay, thank you very much. I think we can get started the webinar on time now, and I would like to have a short introduction of Dr. Prabhu. He's a professor of oral pathology and in charge head Center for Forensic Odontology, Yenei Poya Dental College, Mangalore, India. I know that he has a great collection of cases, and he kindly accepted to share these cases with us in this webinar. And also we decided to have case presentation, just case presentation in this webinar, and share our experiences and knowledge with each other. And after that, Dr. Derakhshan will also share interesting cases with us, and we will have time to have discussion on these interesting cases. Okay, Dr. Prabhu, we are all ears to have your presentation. Could you share your screen?
Yes, sir. Can I, sir, can I share my screen now?
Yes, please. The platform is yours now.
Yeah, thank you, sir.
You're welcome.
So in between it was showing I was muted. Please look into that. My voice is not muted, sir.
Yes, I can hear you now.
Can you see the screen, sir?
Yes.
Yeah. Can I start, sir?
Yes, but would you full screen? Would you make it full
fine
screen?
Yeah. Can I start now, sir?
Yes, we can get started. And would you let's to have discussion after each cases? I think you have provided for us about 4 or 5 cases. What do you think, Dr. Prabhu?
Sir, I have a pattern of discussion in which after each of the slideshow, in between I'll go to the chart box, and I would like to have a differential diagnosis from the viewers, and then I will further go to the next case, sir. Is that okay?
Okay, great. And then the stage is yours, and we all ears to hear your presentation. Thank you.
Thanks a lot, sir. Thank you. A very good morning and good afternoon here, and probably it's already midnight over there in US. First of all, it's a great privilege and an honor to be with you all, and thanks a lot to Dr. Pawan Shakib and Tehran University of Medical Sciences for this opportunity to have an interaction and collaborative learning process. And I'm very grateful to you each and all for joining today's discussion. This is on head and neck lesions, review of some interesting cases. And I would like to thank each one of you before I start. So I would like to thank, and I will be grateful to my alma mater, SDM College of Dental Sciences, Dharwad, and whatever I am today in oral pathology or in forensic odontology, it is because of my alma mater, SDM College of Dental Sciences, Dharwad. And this is the place I'm working right now. This is one of the fastest growing deemed university in this part of the world, NFI deemed to be university in the world. And in that, the dental college being the senior most member, completing more than 25 years of its service to the education field. With that brief expressing my gratitude, I would like to start my first case today. So this is the 11-year-old male patient, swelling in the right side of the mandible, 2 into 2 centimeters, with mixed opacity and lucency, with a long duration of 8 months. Again, I repeat, 11-year-old male patient, 2 into 2 centimeters swelling in the right side of the mandible, mixed opacity and lucency. Usually, such kind of lesions will be thought in terms of a odontogenic tumor, odontogenic cyst, because an young patient, so a fibroosseous lesion. Those are all will be there in your differential diagnosis, isn't it? So our clinician thought it to be an amyloblastoma or odontogenic keratocyst. These were there in their list of differential diagnosis. Let us see the histopathology. We had something like this, trabeculae arranged in the form of homogeneous or uniform pattern with sort of vascular stroma. But if you go in other areas, the predominant areas were showing highly cellular stroma dispersed with trabecula of bone. These cells are really proliferative, plump, and round to ovoid in nature. And these bony trabeculae were immature, with entrapping those cells, osteoblastic cells, highly cellular stroma. We had some areas mimicking round to ovoid, basophilic, cementum-like material. We call it as Samoma bodies. And you can see here entrapped, osteoblasts. Few of the areas were showing aggressive bone destruction and bone formation, mimicking your pagetoid pattern, typical pagetoid pattern having reversal line. Many areas are showing also giant cells, proving that a lot of remodeling is happening, new bone formation and destruction. Now, I would like to go to the chat box. What might be your differential diagnosis? Very good. Dr. Madhu is telling juvenile ossifying fibroma. Dr. Nasir is telling juvenile variant of ossifying fibroma. Anything else? Dr. Pawan Shakib is telling fibroosseous lesion. Dr. Prasad is telling juvenile ossifying fibroma. Fine. Any other diagnosis? I'm waiting for your diagnosis in the chat box. Fine. Most of you are thinking in terms of fibroosseous lesion, mainly juvenile ossifying fibroma. That's how the logic goes. Dr. Nazneen, juvenile ossifying fibroma. Dr. Fibrous, juvenile ossifying fibroma. Fine. And Dr. Homera, juvenile ossifying fibroma. That's great. All of us are thinking the same way as juvenile ossifying fibroma. So juvenile ossifying fibroma was the first differential diagnosis. And whenever you have such aggressive lesion, as I said, there is a lot of bone formation and bone destruction. And we have to have low-grade osteosarcoma also in our differential diagnosis. And the first histopathological image I showed, it was showing a Chinese letter pattern or homogeneous or cuneiform pattern. There are some case reports of late, aggressive variant of fibrous dysplasia. You know, this individual is 11-year-old boy. So the lesion was there for a long time, 8 months. Why not a fibrous dysplasia becoming suddenly aggressive? That was also there in our differential diagnosis. But mind you, most of these cells are round to ovoid, and you have this kind of bony trabeculae entrapping those, osteoblast, highly proliferative osteoblast. And most predominantly, all these cells were epithelioid, round to ovoid with eosinophilic cytoplasm, having the nucleus pushed to the periphery. And these kinds of cells are called as epithelioid osteoblasts. And these kinds of sheets and sheets of cells were there. And it was basically osteoblastic tumor, not a fibroblastic, ossifying fibroma. It's an osteoblastic tumor, which is a closer differential diagnosis to juvenile ossifying fibroma. And thus we concluded this lesion as epithelioid osteoblastoma. Epithelioid osteoblastoma is nothing but an aggressive variant of, osteoblastoma. It mimics juvenile ossifying fibroma. It will have similar appearance and features of juvenile ossifying fibroma or osteosarcoma, but it will have a typical epithelioid osteoblast and without any fibroblastic stroma. So this lesion was aggressive osteoblastoma mimicking juvenile ossifying fibroma or osteosarcoma. So mind you, all three lesions will be having similar features: juvenile ossifying fibroma, epithelioid osteoblastoma or aggressive osteoblastoma, and low-grade osteosarcoma will have similar overlapping features, and including pegydoid bone. You have to differentiate these lesions very carefully, ruling out the possibility. In case of osteosarcoma, we'll have invasive front, atypical cells, anaplastic cells, and a very aggressive behavior. Whereas this lesion, there was bone destruction, but it was a long duration and it was well circumscribed, and it was concluded as aggressive osteoblastoma or epithelioid osteoblastoma. You can see here, that is what you're thinking in terms of juvenile ossifying fibroma. The stroma will be more of fibrous, cellular, but fibrous stroma, not osteoblastic stroma, but it will have semammatoid-like bodies. Semammatoid bodies can be seen in aggressive osteoblastoma also. And in case of osteosarcoma, you will have this kind of the stroma that is, that osteoid, eosinophilic acellular osteoid streaming lace-like in between the cells, merging with the cells. And that is a typical tumor osteoid merging with the cells. It will be a characteristic feature of osteosarcoma. So this particular case, there was no tumor osteoid and the cells were not anaplastic. So it was concluded as aggressive osteoblastoma. So this is a osteosarcoma. Again, you have the tumor osteoid going in between the tumor cells. Whereas in this particular case, tumor osteoid was absent. You had large epithelioid cells. Those are all epithelioid osteoblasts. Sir, can I go to the next case, or you would like to have a verbal discussion?
Yes, I think we can go to the next case and we will have discussion at the end of your presentation.
That's great, sir. Thanks a lot. We'll move on to the next case, a 45-year-old female patient, a swelling of 4 months duration. Mind you, it's a second recurrence. That means the lesion is happening in this area totally 3 times. Middle-year-old female patient, very aggressive lesion, a big swelling in the second molar and first molar area. And you can see the image here, radiographic image here, lot of bone formation and destruction also. And it's a second recurrence. Histopathologically, again, a bony lesion having 2 components, stromal component and an osseous component. Stroma is not so cellular compared to the previous case, and you have a lot of bony component also. The cells, if you appreciate here, are round to ovoid and vesicular with open nucleus. You can see the nucleoli, a lot of pleomorphism and hyperchromatism, but you can see some acellular eosinophilic material in between the tumor cells. The stroma looks cellular and a lot of immature bone formation, but highly pleomorphic and anaplastic cells, along with eosinophilic acellular material streaming in between these tumor cells. That is very peculiar. And you had a lot of mitotic figures also, highly pleomorphic and anaplastic cells. Even mitotic figures, and you can see the nucleoli, open face nucleus with nucleoli visible inside. You can see a lot of acellular eosinophilic stroma. And this is very characteristic. I'm not going to speak about this now. I'm going to tell about this area later on, but observe carefully. This is highly characteristic in this particular case. And you can see the tumor cells in sheets and a lot of osseous component in between. Observe this area carefully. I'm going to discuss about this later. This one, very characteristic stromal component, which I'm going to describe later. What is your differential diagnosis? Go to the chat box. This particular case, can I have your differential diagnosis? I'm waiting for your reply. Can I have a differential diagnosis for this particular case? No reply from your side. Very good. Dr. Homera is telling osteosarcoma. Dr. Prasad is telling chondroblastic osteosarcoma. Dr. Madhu, chondroid-related malignancy. Very good. Dr. Olidhiran is telling osteosarcoma. That's great. Everybody is thinking in terms of osteosarcoma. Now let us go to the diagnosis. The differential diagnosis we have in your mind is aggressive ossifying fibroma, just like juvenile ossifying fibroma. Here it is middle-aged, so we cannot call it as juvenile. We better call it as aggressive ossifying fibroma. Aggressive osteoblastoma, just like a previous case, epithelioid osteoblastoma, and of course, osteosarcoma. Mind you, this lesion has come thrice, and I'll tell you, the first time it was diagnosed as ossifying fibroma when it came 2 years back, it was diagnosed as ossifying fibroma. And the second time it came, there was a lot of bone destruction and some amyloid like bodies were there. And we gave the diagnosis as aggressive ossifying fibroma. And third time it came in this manner. And this time it was definitely an osteosarcoma. And you were right, that particular area was a chondroid like stroma. And of course, only one area was showing chondroid, and you cannot call it as chondroblastic variants as Dr. Prasad has told, but only one area was showing typical chondroid stroma. But mind you, chondroblastic osteosarcoma is one of the aggressive variant of all the three types of osteosarcomas compared to the fibrous and the osteogenic osteosarcoma. So this was a case of osteosarcoma, but it was very low grade, and it was very less aggressive in the beginning. It was like a small swelling in the first occurrence. It was diagnosed as ossifying fibroma. It became very aggressive in the second time. We called it as aggressive ossifying fibroma, and finally it turned out to be an osteosarcoma. There is a history of such things happening. These fibro-osseous lesions can turn into really aggressive osteosarcoma simultaneously or later on. So that's about the second case. And as I told you, you should keep all these differential diagnoses in your mind when you go for such fibro-osseous lesions. So this place of Mangalore is very famous for ice creams. So if you visit this place, of course, you visit India, probably in the future, once the COVID is over, you should visit our place and we should taste the ice cream over here. Anyway, we'll move on to the third case. You can see a large lesion starting from the canine region, right side of the maxilla, ending towards the second molar. And the lesion is extending into the sinus, a very big lesion, and duration of 4 months. What might be your differential diagnosis at this stage? Seeing the radiograph, radiolucent lesion involving the maxilla and the maxillary sinus. What might be your differential diagnosis at this stage, clinically? I'm waiting for your response in the chat box. It's a middle-aged, middle-aged person. Any differential diagnosis? Radiolucent maxillary lesion involving the sinus. There is perforation into the sinus. Any differential diagnosis, clinical differential diagnosis? Odontogenic cyst, ossifying fibroma, fine. Fibro-osseous lesion is the differential diagnosis you have given, fine. That is how we think. Most of the time, jaw lesion, it might be odontogenic cyst or odontogenic tumor or fibro-osseous lesion involving the sinus. 32-year-old male patient. Let us see the histopathology. Histopathologically, it was mostly like a cystic lesion having pseudostratified ciliated columnar lining with a lot of, mucus-like cells, goblet-like cells, tall columnar cuboidal cells with ciliation, pseudostratified ciliated columnar cells with a lot of goblet cells or mucus cells. Typical hourglass appearance, characteristic feature of goblet cells. And you have some cystic spaces filled with mucin-like material and lined by clear cells and round to ovoid cells with spherical nucleus, and some ciliation and filled with mucin, these cystic spaces. Few cystic spaces were there with such mucin pooling. And lot of inflammation, of course. Chronic inflammatory cells in the stroma. That means there is a history of chronic inflammation in that area. All these mucin was positive for pus and mucicarmin. That means definitely it was mucin positive. All the lining cells which were like goblet-like cells were positive for mucicarmin and pus also. Previous pictures were for pus, and this is mucicarmin positivity. What is your differential diagnosis? Let us go to the chat box. Very good. Glandular odontogenic cyst. Dr. Madhu is telling glandular odontogenic cyst. Dr. Nasir is telling odontogenic sinusitis. Very good. And neospeculis is combined. Dr. Nasir is telling mucoepidermoid, or otherwise glandular odontogenic cyst. Dr. Oludhiran Daniel is telling xyloodontogenic cyst. Very good. Odontogenic area, but there is a perforation into the sinus also. Dr. Nazneen is telling low-grade mucoepidermoid carcinoma. Very good. That is also a possibility. Homera is telling MEC mucoepidermoid carcinoma. Fine. Lot of mucicarmin stain positive cells were there. Pus positive cells were there. Mucus cells were there. Dr. PPM MEC low grade. Very good. Glandular odontogenic cyst and mucoepidermoid carcinoma is the differential diagnosis, and that was also our differential diagnosis. GOC, low grade MEC. Dr. Sai Krishna, low grade MEC. We also thought in terms of MEC and GOC in our differential diagnosis. You are right. You are 100% right. We were also thinking in terms of glandular odontogenic cyst or otherwise low grade MEC. But we also thought of, because there is a perforation, we also thought the lesion might be originating from the sinus mucocele, or otherwise cyst of sinus. There is a lot of chronic inflammation was there, whether it is a sinusitis, then otherwise lesion coming out of the sinus into the jaw area. We were not sure whether the lesion was originating from this maxilla and going into the sinus, or originating in the sinus coming into the maxilla. But this particular case was finally diagnosed as traumatic ciliated cyst. Mind you, all these features will be similar in glandular odontogenic cyst and a cyst associated with the maxilla sinus and even low-grade MEC. But this particular case, GOC was ruled out because I showed you the entire lining everywhere. The lining was pseudostratified ciliated columnar. There was no epithelial thickening or epithelial plaque. Rather, there was always a goblet-like cells, and it was mostly a ciliated lining. And there was a history of trauma, which I have not intentionally mentioned in the history of in the beginning. There was a history of trauma in this region, and it was resulted in a sinus cyst and perforated into the jaw. All the teeth were vital. There was no problem with the teeth involved. Traumatic ciliated cyst is nothing but a surgical ciliated cyst only. Depending upon the history, we call it as either surgical ciliated cyst if there is a history of surgery, traumatic ciliated cyst if there is a history of trauma. If there is no either history, we call it as sinus cyst. They mimic exactly like the glandular odontogenic cyst or low-grade MEC. It's very difficult to differentiate it between glandular odontogenic cyst and the low-grade MEC, because features will look similar depending upon the clinical history, behavior, and the histopathological feature. We conclude it as a GOC or MEC. Thanks for your very good responses. GOC was the closest diagnosis for this case. So our place is not only famous for ice cream, our place is famous for even, a fish. We get amazing fish in this area. So when you visit our place, you should taste the variety of fishes in our place. So let us go to the next interesting case. Fine. A swelling in the maxillary zygomatic region, mainly in the temporal fossa. Fine. Extending up to the lower border of the mandible. Mind you, it is behind the mandible in the temporal fossa region, going up to the border of the mandible. That is the size, just to imagine the size of the lesion, a very big lesion, but looks like it is encapsulated. Fine. It looks like encapsulated. A 24-year-old male patient, and 5-month duration for the swelling. Again, it's a recurrence. And I will tell you the previous diagnosis at the end of the discussion of this particular case. 5 months duration, well encapsulated lesion behind the mandible in the temporal fossa, extending from maxillary to zygomatic region, 24-year-old male patient. Highly encapsulated lesion. Stroma looks more of fibrous rather than hyalinized, and also highly vascular. Large dilated vascular channels, highly vascular lesion, dilated vascular channels. Stroma is hyalinized, collagenous stroma, mature stroma. You can see here, highly mature collagenous stroma with, spindle-shaped fibroblast compressed in between the collagenous stroma. But mind you, the stroma is also highly vascular with dilated vascular channels. Many vascular channels. And out of curiosity, we did toluidine blue staining. Lot of toluidine blue positive mast cells were present. Highly vascular and collagenous stroma with mast cell positivity. Significant predominant number of mast cells are also present. What is your differential diagnosis? Go to the chat box. Fibromyxoma. Myxoma, this lesion was not loosely arranged stroma, rather compactly arranged hyalinized stroma. If it was myxoma, the stroma will be loose and highly delicate stroma will be there. Here the stroma is more of compact and rigid fibrous stroma. So it is not a fibromyxoma, but definitely a good differential diagnosis. Malignant fibrous histiocytoma is from Dr. Madhu. Okay, we'll discuss about that. Dr. Mahija is thinking in terms of angiofibroma. We'll think about it. Dr. Homera, hemangiopericytoma, very good. There is a vascular differential diagnosis also. Dr. Sai Krishna is thinking in terms of myxoma, cut section mimicking myxoma. The cut section, the gross, it was a rigid lesion, very firm lesion. It was not having any jelly-like, otherwise soft stroma. It was highly, very good. Dr. Nazneen is thinking in terms of solitary fibrous tumor. Fine. because there is a lot of vascularity and collagenous stroma. Dr. Madhu Narayan is thinking in terms of plexiform fibrous tumor, histiocytoma, fibrous histiocytoma. Fine. Staghorn shaped cells, vessels. Okay, fine. That was there. Staghorn like vessels, vascular hemangiopericytoma, or otherwise solitary fibrous tumor, and hemangiopericytoma, angiofibroma. All these possibilities are there. Fibromyxoma appearance, I agree with you, but this lesion was not showing any myxomatous stroma. The lesion was completely compactly arranged, highly hyalinized collagen fibers, no loosely arranged myxoid stroma. Anyway, mast cells were positive. That is also an interesting finding. Anybody would like to think about mast cells? Considering mast cells and fibrous stroma, anybody would like to give a differential diagnosis? I'm waiting for your response. Then I'll go to the diagnosis. Significant number of mast cells were there. Which lesion will have significant number of mast cells? Neurofibroma. Dr. Nazneen is telling neurofibroma. Dr. Prasad is telling neurofibroma. Mind you, 1 year back, this lesion was happening in the same area, very small lesion, and that time also significant number of mast cells were there, and it was diagnosed as neurofibroma previously 1 year back. Neurofibroma, Dr. Marina is telling neurofibroma. Yes, 70% of the time neurofibroma will be associated with the mast cells. Differential diagnosis were neurofibroma because of the mast cells, and as you said, solitary fibrous tumor and fibroma and hemangiopericytoma also can be there because a lot of vascular channels were there. But interestingly, this diagnosis was, as one of the delegate told, it was nasopharyngeal angiofibroma. It is very difficult to differentially diagnose all these possibilities. And remember, mast cells can be present in all these lesions: neurofibroma, solitary fibrous tumor, angiofibroma. In neurofibroma, mast cell is an initiating factor. It is a pathogenetic factor. Mast cell will secrete neurogenic growth factor. That neurogenic growth factor will induce the proliferation of the neural component. It's a histogenetic factor in neurofibroma. Whereas solitary fibrous tumor and angiofibroma, it is just a coexisting factor. So mast cell can be present in all the three lesions: neurofibroma, solitary fibrous tumor, and angiofibroma. We had all these three possibilities in our differential diagnosis. But remember, in case of solitary fibrous tumor or hemangiopericytoma, this lesion can be either benign or malignant. It can be cellular or fibrous. If it is cellular stroma, it goes more in terms of hemangiopericytoma. And if it is more of fibrous, it goes in favor of solitary fibrous tumor. And though it was a capsulated lesion, this particular lesion, it was happening in the temporal fossa. It was very aggressive and it was spreading like anything. It was diagnosed as angiofibroma. So in addition to the ice creams and the fishes, I would like to mention you about something like, lentil soup. We call it as a variety of lentil soup, which is also famous in our area. With that note, I would like to conclude. One more case is there. Can I go ahead, sir? I will take only 5 minutes. Can I go ahead for one more case, sir? I will take only 5 minutes.
Yes, Dr. Prabhu, you can go ahead. We have time about 5 to 6 minutes.
That's great, sir. Thanks a lot. I'll finish before that. Thank you. So one more interesting case. I'll finish in another 5-6 minutes. 45-year-old male patient. There is a smoking history of 20 years, 5 months duration, a very big ulcer on lateral border of the tongue. Usually, whenever there is a tobacco history is there, non-healing ulcer for a long duration with tobacco history, we always think in terms of squamous cell carcinoma. That is a usual concept. But see the histopathology. Mind you, it's a tongue ulcer, very aggressive lesion having both round to ovoid cells and spindle cells arranged in the form of sheets, lot of mitotic figures, round to ovoid and spindle cells, pleomorphic and hypochromatic, bizarre nucleus are also seen. Highly aggressive lesion having two types of cells, totally biphasic, aggressive variant of tongue ulcer. As I said, predominantly each and every area was having mitotic figures in different phases. And you have some kinds of cells, you can appreciate them, something like strap-like or tadpole-like cells. Mind you, it is a tongue lesion, tongue ulcer. I'm not sure whether this is a lesional cell or a background cell because it's a tongue ulcer. You can see long elongated tadpole-like or strap-like cells with bizarre nuclei and mitotic figures. Biphasic lesion. Rhabdomyosarcoma, very good. That was the first thing came to our mind. But remember, squamous cell carcinoma is also a possibility because tobacco history there for 20 years. Everybody is thinking in terms of rhabdomyosarcoma. Dr. Nasir, rhabdomyosarcoma. Dr. Madhu, rhabdomyosarcoma. Dr. Nasir, immunohistochemistry is done. I'm going to tell about that later. Professor Dr. Sai Krishna, rhabdomyosarcoma. Dr. Homeras, Dr. Rhabdomyosarcoma. Dr. Poyan Shakabi sir is telling IHC is necessary. IHC has been done. I'm going to tell that later. Dr. Madhu is telling spindle cell variant of squamous cell carcinoma. Yes, that is also a possibility because there is a tobacco history. Fine. All these possibilities were there in our differential diagnosis. It's a biphasic lesion. Spindle cell carcinoma has to be there in our differential diagnosis. Tobacco ulcer, tobacco-related ulcer, 20-year history of tobacco ulcer is there. Rhabdomyosarcoma was there in our diagnosis, and definitely malignant fibrous histiocytoma because it's a biphasic tumor having both round and spindle cells. And malignant melanoma, that is without much melanin pigmentation, that is amelanotic melanoma. Only for the histopathological differential diagnosis interest I have added, but otherwise it is not having any feature. Only for the discussion I added malignant melanoma. But remember, the epithelium, overlying epithelium was completely normal. It was not showing any histopathological dysplastic features. Epithelium is completely normal. Rather little bit of hyperplasia is there. And the lesion was well separated from the epithelium. And there was a stroma between the epithelium and the lesion. So the spindle cell carcinoma was ruled out because the lesion was not originating from the overlying epithelium. And for our surprise, histopathologically, this lesion was, showing vimentin positivity. It was cytokeratin negative, HMB45 negative, S100 was negative, and it was showing smooth muscle actin SMA positivity rather than, it was not showing any positivity for skeletal muscles. And we also thought in terms of rhabdomyosarcoma because of those strap-like cells or tadpole-like cells. But later on, because it was showing a lot of SMA positivity, we went back and saw this kind of blunt end nuclei. And because it is biphasic, it is not a round cell tumor, the diagnosis was given as epithelioid leiomyosarcoma. It was very surprising for us. This particular case was This particular case was thought in terms of rhabdomyosarcoma, or otherwise spindle cell carcinoma. For our surprise, it turned out to be a leiomyosarcoma because of the IHC positivity. All these cases will mimic each other. The features will be overlapping. But remember, in case of rhabdomyosarcoma, the nuclei will be still more bizarre and it will be highly anaplastic compared to the leiomyosarcoma. And in case of malignant fibrous histocytoma, you will have that characteristic storiform appearance. Of course, all these biphasic tumors, they look alike. IHC is mandatory. So with that note, I would like to conclude and humbly thank Dr. Shakib for this opportunity and Tehran University of Medical Sciences for this interaction. Thank you. Thank you.
Thank you, Dr. Prabhu, for your nice presentation. And it was great, challenging cases. And if you would let us, we can get started the discussion on your cases, because we have about 5 to 10 minutes to have a brief discussion on your cases. Let me start with the last case, because I think it was very tricky case. You have a IHC study on this case, and I think you immediately ruled out a spindle cell carcinoma because you use cytokeratin. In such cases, we commonly suggest to have other epithelial markers such as P63 or epithelial membrane antigen. And also one of our audience mentioned that we saw that there was an ulcer at the surface of the lesion at the lateral border of the tongue. Would you please let me know how you interpret such findings, and do you use just one biomarker, IHC biomarker, to confirm or rule out the entity of the origin of the lesion?
Fine, sir. Thanks a lot for that question, sir. I would like to elaborate on that. First of all, cytokeratin was done. Simultaneously, vimentin is done. So the moment vimentin is positive and cytokeratin negative, it indicates toward mesenchymal lesion. Vimentin cannot be positive in squamous cell carcinoma. So once vimentin is positive, there is no need of any other epithelial marker. Is that okay, sir?
Yes, I do understand what you explained, but I think I don't want to have a long discussion on this panel, but on this case, but I think one biomarker for epithelial origin might not be enough to confirm or rule out the origin of the cells, of undifferentiated cells. Also, Professor Nasser well explained that P63 could be helpful. Also, we can see vimentin positivity in several cases of spindle cell carcinoma. Also, we may see a smooth muscle actin positivity in several cases. Okay, I think Dr. Krishna want to add something to the panel. Dr. Krishna, could you, Zohra, could you turn on, could you give access to Dr. Krishna? Dr. Krishna, could you turn on your webcam and microphone? Let me check. Krishna. I think you can talk now. Dr. Krishna?
Yeah, that very crisp and nice presentation, Dr. Sudeendra.
Thank you, sir. Thanks a lot.
Yeah, excellent presentation, and a little confusing to diagnose, I think. But the tongue lesion, tongue
sir.
lesion was there. Now, clinically, when we see the lesion, you said the surface epithelium looked normal.
Yes,
But
sir.
the ulcerated area,
Yes, sir.
we need to see slides from the ulcerated area, how it goes, as well as from the epithelium where the ulcerated area, where the fibrinous exudate will be there, and from there, how the cells are changing, that one. And even like our moderator told, one panel is not sufficient because the clinical picture looks like a squamous cell carcinoma as well as traumatic ulcerative granuloma with stromal eosinophilia. The clinical picture looks like that. But by and large, maybe you have done the smooth muscle actin you have done, and you have confirmed it as a leiomyosarcoma, which is a very rare neoplasm which occurs in the oral cavity. That it's a nice case, just to discuss that one. And the other case which you had near the zygoma, where the cut section, no? We could have that cut section shows exactly like the palm tree fruit, no, inside. That cut section, it shows like a palm tree fruit.
Yes,
But that palm tree fruit will be slightly like jelly.
Yeah.
A little firm, and it will be like jelly. But later only we came to know that it is hard, though it's capsulated one.
Yes, sir.
And the distractor is, you focus the slide, it looks like samoma like ossicles.
Yes, sir.
Which is present in the near to the fourth ventricle of the brain. So it resembles that.
Yes, sir.
I'm a faculty, I'm heading department at Tagore Dental College, Chennai.
Oh, sir. Nice meeting you, sir. Nice interacting with you, sir.
I will be coming to Mangalore after the third wave to drop my daughter in Manipal. That time I will come and meet you.
Definitely, sir. Definitely. You can visit us. Sir, a nice observation. And to elaborate, sir, this particular case, it was a very, very difficult case. As you said, the last one, we thought in terms of spindle cell carcinoma only. That was our first diagnosis. And rhabdomyosarcoma because of some features. And we happened to send this particular case to Mumbai, Tata Institute of Cancer for further evaluation, sir. We have not diagnosed it on our own. We send it for a higher center, and all the possible markers has been done and ruled out. And this is the final marker what they have sent us. We have tabulated, but they have ruled out all the
just a suggestion.
Yes, sir.
You have done an excellent presentation. You can also send one copy to Mayo Clinic.
Oh yeah, like that, sir. You mean to say
apart from Tata Memorial, Mayo Clinic, so you will get a comprehensive differential diagnosis to narrow down for that case.
Sure, sir. Sure, sir.
That one also, it looked like a miscellaneous aggressive fibrous lesion.
Yes, sir.
Which you, you told it's a rhabdomyosarcoma, and even that the case in zygoma.
Yes, sir.
It was confusing for a miscellaneous aggressive fibrous lesion.
Dr. Yes, Krishna, thank you. Sorry for interruption. Thank you for your comments. I think a greater panel is necessary for such challenging cases, including P63, including other, skeletal muscle biomarkers to make a definite diagnosis. As Dr. Prabhu well explained that he has a more panel for this case, but he didn't show all of these biomarkers in this presentation. But I think spindle cell carcinoma at the first differential diagnosis of such lesion in oral cavity and should be ruled out by sure with a descriptive immunohistochemical staining panel. Thank you for your presentation. I think we don't have enough time for have more discussion on this part. And if you would let me, we will go to the next presenter, Dr. Derakhshan, and we will, if we would have time, we will get back to Dr. Prabhu. Thank you, Dr. Prabhu. Please stay with us until the end of this webinar.
Thanks a lot, sir. Humble thanks to each one of you for the active participation and the opportunity. Thank you.
You're welcome. Okay, at this part of the webinar, we have Dr. Samira Derakhshan, Assistant Professor of Oral and Maxillofacial Pathology, Department of Tehran University of Medical Sciences. Also, she's Vice Head for Educational Affairs at the department. Dr. Derakhshan, thank you for accepting my invitation to this panel, and we are all ears to see your interesting cases.
Thank you, Dr. Shaki, for nice introducing. Hello, everyone, dear professors and also dear colleagues. Hope you are doing well. You hear me today from Tehran University of Medical Sciences, School of Dentistry. I would like to express my appreciation to all of you for joining this scientific program, and I hope it was informative and also interesting for all of you. Today I'm here to presenting some three challenging, really challenging cases in our department. And first, please let me to full screen. First, I would like to thank all of my dear colleagues in oral and maxillofacial pathology department, all of my dear active colleagues. All of my today cases have been appropriated and signed out in collaboration with them, and it's a great opportunity and a great pleasure for me to being a member of this glorious family. If you let me, I started my presentation with the case number 1. The case number 1 was, the first one was a 2 years old female with no significant past medical and past dental history. She referred to oral maxillofacial surgeon in TUMS with an abscess-like lesion in her right mandible, right angle of mandible, for about 2 months based on the her parents' reports. Clinical examination of the patient relieved facial asymmetry by the non-tender and prominent swelling in right angle, right mandibular angle with firm consistency. As you see here, the patient, she was very crying, always she was crying and she was very agitated, and you see the prominent swelling and facial asymmetry, but the lesion was non-tender and without any pain. You see here the computer tomography view of the lesion. You see here radiolucent in bone windows of the lesion. You see expansal lesion and the extension of the lesion in the another site in area of unerupted the teeth number E and D, and also the lesion is due to tooth resorption in root area in some regional tooth. And also here in also bone windows of CT scan, you see the nature of the lytic lesion in area of right bramus of mandible. Incisional biopsy was done for the patient, and you see the microscopic view. Also, you see in the upper view the gross microscopic view of the incisional biopsy of the lesion. The material was irregular, firm, soft tissues, and with firm consistency. And also you see the macroscopic view, rather hypercellular region composed of spindle cells arranged in short fascicle and also haphazard pattern. And also you see a background of myxoid to fibroid material and thin collagen fibers among the tumoral cells. You see here the high power field of the lesion that as you I'm sure that you confirm me that the lesion has at least ATP and also nuclear ATP and pleomorphism, and we didn't see any atypical mitotic figures. And you see here the admix of spindle cells with thin collagen fibers in a myxofibroid stroma. In IHC or immunohistochemistry study, the tumoral cells react for beta-catenin as a severe strong nuclear pattern, as you see in the lower picture here. And here the IHC study for alpha SMA, you see here a rather weak brown nuclear immunoreaction, but it was not significant for us because we have a beautiful internal control, a section of blood vessels which demonstrates severe cytoplasmic immunoreaction for alpha SMA, and we did not have any area of cytoplasmic immunoreaction for alpha SMA and also nuclear reaction in some cases. Based off this area, the diagnosis of a spindle cell tumor without significant atypia and mitotic activity in collagenous stroma compatible with the small-plastic fibroma was reported for the patient, and the patient undergone to the surgical treatment to the resection of the whole lesion. And also you see here the mandibular reconstruction plate was used for the patient to restore the mandibular contour. And in the diagnosis of the whole excited lesion in the hospital, you see the IHC result, and also which confirm the previous IHC result in our department. And also you see the diagnosis of juvenile desmoplastic fibroma for the patient. And now you see the follow-up of the patient after 6 months and also 12 months after the surgery. You see here 2 years after the surgery, there was not any evidence of the recurrence and also no significant problem for the patient. He was happy and healthy. And also about 1 month ago, as you see here, you see the follow-up of the patient for 4 years after the surgical treatment of the patient. There is any mild deviation in mouth opening. Also, there was any evidence for recurrence and any noticeable problem for the patient. And she was happy and being familiar with the clinicians and her surgeons also. We reported these cases of desmoplastic fibroma with 2 another cases of desmoplastic fibroma in the Iranian Journal of Pathology about 2 years ago, with a collaboration with the surgeon and also the oral maxillofacial radiologists that's helping us to diagnosis and management and also treatment of the patient. As a take-home message for this case, I would like to say that as we mentioned in the conclusion of this paper, also despite the aggressive nature of desmoplastic fibroma, as you know that desmoplastic fibroma is a borderline lesion, benign malignant or between malignant and benign lesion. It is a borderline lesion with an aggressive nature, but in young patients often respond very well, as you see in our cases, very well to wide resection treatment. And it's very important point that the early diagnosis of this aggressive and borderline lesion is very important that we have facing to these lesions. If you agree, I go to the case number 2. 36 years old female with no significant past medical and also past dental history was referred to our department, and she has a painful mandibular expansal lesion for about 7 months. You see here the panoramic view of the lesion. As you see here, between the area of second premolar and first molar teeth, there is a rather radiolucent lesion, as you see here, that it's mimicking, it is very mimicking endoperial lesions in this area. And there is no more information in this panoramic view. But in a periapical view of the lesion, you see here that the level of the alveolar crest in the area of interdental area between the second premolar and first molar teeth is increased in the comparison to the alveolar crest in the area of between the interdental area between the premolar teeth and also between the first premolar and canine tooth. You see the increasing in alveolar crest level of the bone, and it's very important for us, and it's not a sign of endoperial lesion in any area of tooth-bearing area. And the surgeon's impression in a clinical view of the lesion, as you see here, he reported for us that he faced to a solid lesion with increased periodontal ligament thickness in the same area, and also the alteration in the trabeculation in the bone in the same area. And as you see here, the differential diagnosis of the clinical impression of the surgeon, you see lymphoma, osteosarcoma, and also other sarcomas. This differential diagnosis was very different for us based on the radiographic view that we see a very small lesion. But in incisional biopsy, as you see here, in connective tissue underlying the intact superficial epithelium of the oral cavity, we face to hypocellular lesion composed of spindle cells admixed with bone trabeculae and arranged in myxoid stroma, as you see here. And in deeper area, the pleomorphism of the tumoral cells is increased, and we face to hyperchromatism and also cellular atypia, and also pleomorphism of the tumoral cells, and also malignant bone trabeculae. As you see here, we face to cellular and nuclear atypia, and also hyperchromatism and pleomorphism of the spindle cells of tumoral cells, and eosinophilic material between the cells, admixed with malignant bone trabeculae. In this here, I would like to flash back to the periapical lesion and mention the the level of crystal bone, alveolar crystal bone, and that it was very challenging for us to differentiate and make a definitive diagnosis for the patient, and it was very challenging for us based on the differential diagnosis of the clinical impression of the surgeon. And here in this situation, we consult with an expert oral and maxillofacial radiologist, and as you see here, her report here, and I translate it and read it for you. An ill-defined radiolucent lesion, band-like periodontal ligament widening, and there is an important point, new bone formation in crystal and also interdental areas. It is a very important point for us. And he reported malignant bone-forming tumor, osteosarcoma, most probably central type. And he recommended the CT or CBCT evaluation of the lesion for more evaluation for the location and extension of the lesion. Based on this consultation with expert radiologists, we reported osteosarcoma with any evidence of necrosis and 2 to 3 mitotic figures in 10 hypolar fluid, and also we reported in a comment for the surgeon that according to consultation with an expert oral maxillofacial radiologist, conventional intramedullary osteosarcoma is the most probable diagnosis. After that, the CT scan was done for the patient, and you see here the soft tissue windows with contrast, also IV and oral contrast for the patient, and you see the extension of the lesion mainly in peripheral area of the bone, and you see here in the upper view in soft tissue windows, and in the down picture you see the bone windows of the CT scan of the patient, and you see in the bone windows here, you see here in bone windows of the lesion the involvement of intramedullary area and central location of the lesion with a prominent extra osseous or peripheral components. Based on the first diagnosis in the incisional biopsy of the lesion, the patient received neoadjuvant therapy, chemotherapy, and also after that he underwent the surgical resection of the tumor with the safe margins, as you see here, and custom-made custom template was used for the patient for remaining the continuity of the mandible and the mandibular contour. And finally, in the macroscopic evaluation of the whole lesion excision, as you see here, the pleomorphism of the tumoral cells and also the nuclear atypia, cellular atypia in tumoral cells was abundant and increased versus comparison in the incisional biopsy. As you see here, spindle cells admixed with eosinophilic area maybe respond to chemotherapy, and also you see a numerous tumoral cells, giant tumoral cells, or Bezier cells between the neoplastic cells, and we face to severe pleomorphism of the malignant mesenchymal cells or malignant osteoblastic cells. You see here in this view the involvement of a mandibular nerve or V3 nerve in the evaluation of excited lesion. And this view is a confirmation for the involvement of the intramedullary area, and a confirmation for the first conventional osteosarcoma diagnosis. And it was very challenging for us to the face with the patient and to the choose the best treatment plan based on the peripheral or central type of this lesion. And you see here the report of the final for the patient and for whole excited lesion. Conventional osteosarcoma has been diagnosed for the patient. There is an important point as a take-home message for this tumor and for this case, and maybe the superficial low-grade parostal osteosarcoma may be involved the intramedullary area, but it's very, very minimal, and in at least amount of the intramedullary component. But versus in the intramedullary conventional osteosarcoma has a significant intramedullary involvement, and also in some cases occasionally this intramedullary conventional type maybe has a significant soft tissue component. As our cases I presented for you, intramedullary conventional osteosarcoma has a significant soft tissue component in some cases, and in these cases it was very challenging to differentiate between the peripheral low-grade parostal osteosarcoma and also between the intramedullary conventional osteosarcoma. And it's very important here to evaluation of the lesion extension. It's very necessary and very mandatory to take a computer tomography or MRI, magnetic resonance imaging evaluation for the decision and also for evaluation of the lesion extension. And if in some cases we face to a lesion with prominent soft tissue component, but in also facing with the prominent intramedullary component, conventional intramedullary osteosarcoma is most probable diagnosis based on this fact that we agree and the literature agree that in the surface lesion, the main tumor usually is within the soft tissue with a minor intramedullary component, no in the extension, severe or abundant prominent extension in the intramedullary area. And it's an important point that the parostal low-grade osteosarcoma of the mandible is very infrequent in craniofacial bone, and only 14 cases of parostal osteosarcoma has been reported in the literature, and the last one was reported in 2018, as you see here in the paper. I would like to say special thanks to Dr. Atogaraji for invaluable help, and also with for great collaboration and in data gathering for the case number 2. As you see here, the surgical pictures during the surgical treatment. If you agree, I start the case number 3, and it is the last cases. The last case was the 38 years old male without noticeable past medical and also past dental history, with an expansal painful lesion in the mandibular ramus for unknown duration. You see here in a panoramic view the lesion in the angle of mandible in right side, the widening and increased width of the ramus and mandibular angle in this area. It's not very clear in a panoramic view. But you see here a better view of the lesion, a mixed lesion, radiolucent with central radiopacities structures in the lesion. You see here the borders in this view is well defined in the most areas. But here in the CT scans, the bone windows of the lesion without contrast, you see a mixed more radio-opaque lesion in the area of mandibular ramus with abundant extension in lingual aspect, and you see some area of sun ray or sunburst in the lower pictures, as you see here. Some area mimicking sun ray or sunburst with perforation of the lingual aspect in the area of the lesion. The radiographic differential diagnosis was osteosarcoma, chondrosarcoma, and other sarcoma. Based the view you see in the previous slide. The incisional biopsy was done for the patient, and also you see here the microscopy examination of the incisional biopsy of the lesion. In this view, a sheet of small cells admixed with blood vessels. You see vessel sections admixed in the tumoral cells. You see here a better view, high power field of the view of the lesion. A sheets of a small round cell, you see in a very dense background, very little background or stroma. You see here the vessel admixed in the tumor. Area of maybe necrosing, mimicking necrosing, and some larger blood vessels admixed with the tumoral cells. In this view, you see the tumoral cells better, small cells, a small round cell with very few cytoplasm admixed with numerous blood vessels, thin blood vessels you see in various size from large to new formative blood vessels, and also RBC extravasation between the tumoral cells you see here. The ATP was minimal, and all of the tumoral cell showed uniform pattern in several subserial sections of the lesion. You see here better the highly vascular network between the tumoral cells and a mild cellular atypia. Some of the blood vessels structures mimicking a staghorn structure like here or here, a staghorn pattern. But we face to a small round cell tumor, as you see here. I took several pictures of this lesion because you see the highly vascular and also the vessel-rich stroma of the lesion, as you see here, and also some of them was a staghorn pattern. You see here the hemorrhagic background of the tumor in some area, as you see here. And if you agree with me, the atypia, nuclear atypia was very mild, and the tumoral cells was very uniform, as you see here. But no spatial pattern was observed for the tumoral cell between the tumoral cells. In differential diagnosis of small round cell tumors, The main of them are lymphoma, Ewing sarcoma or peanut family, melanoma, undifferentiated carcinoma, small cell osteosarcoma, mesenchymal chondrosarcoma, embryonal rhabdomyosarcoma, and also neuroblastoma. And there is the main differential diagnosis, not all of them, in facing with small round cell tumors. The diagnosis of lymphoma is very important based on the different treatment plan, and lymphoma has not a need to surgical treatment. Also, only chemotherapy for the patient is done, and also the diagnosis of lymphoma is very important for the surgeon. And also melanoma is based on the very aggressive nature of the tumor, is very important for the choosing the best treatment plan, best surgical plan, and also maybe the patient with malignant melanoma received no adjuvant chemotherapy before the surgical treatment, and because of this reason, it's very important for the surgeon to differentiate. Pathology can differentiate between lymphoma, melanoma with other sarcomas. And also in undifferentiated carcinoma, based on the size of the lesion, maybe it was necessary to radical neck dissection for some of them. It's very important to differentiate between carcinoma and also sarcomas in head and neck regions. You see here the IHC study result in some the next slides. As you see here, Ki-67 was very high, and about 30 to 40% of the tumoral cells demonstrate positive immunoreaction for Ki-67. You see here CD34 and also CD31, the immunoreaction positivity in the vascular network or vessel-rich stroma of the lesion is very prominent here at these pictures. Is a confirmation for highly vascular network of the lesion, but nuclear of the nuclear cells has not any positive immunoreaction for CD31 and CD34. And you see here CD99, positive immunoreaction in membranous pattern. You see here between the tumoral cells. You see here S100. S100 in tumoral cells relieved scattered positive cells between the tumoral cells with a strong positive immunoreaction, but in few scattered cells, not all of the cells, as you see here. CD45 or LCA, leukocyte common antigen, was negative in tumoral cells. As you see here, only scattered positive cells was observed, and these scattered positive cells were inflammatory cells among the tumoral cells. And in the end of the IHC study, we use EMA, and you see here the negative immunoreaction for the EMA antibody. This report has been reported for the patient in the area of mandible right angle for incisional biopsy, infiltrative high-grade small round cell sarcoma with highly vascular network, and with necrosis was reported for the patient. And as you see here, based on this fact that we know that osteosarcoma and chondrosarcoma is very common than the other sarcomas in head and neck regions, we take several subserial sections for finding any evidence of bone or chondroid material or calcified material, and there is not any evidence of this calcified material in several subserial sections, and we mentioned this for the surgeon. And also you see only infiltrative high-grade small round cell sarcoma was has been reported for the patient, and after this large panel of IHC study, we cannot find or discover the origin of this small round cell. And the comment was the whole lesion excision is necessary for the definitive diagnosis. Only we can exclude lymphoma and other carcinomas. The patient underwent the surgical treatment for treatment of the sarcoma, and also you see here the surgical treatment of the patient. You see the whole excited lesion. And finally, in the evaluation of the whole lesion, based on a few area of malignant cartilage formation, diagnosis of mesenchymal chondrosarcoma was reported for the patient. And it's very important for us, and it's very challenging and very also interesting for us that in the incisional biopsy after subserial sectionings, we didn't find any area of calcification or calcified material, any cartilage formation or others. And in whole lesion excision, in the evaluation of the whole lesion, as you see here, about size of the lesion is, I can't find the size. Yes, here, the greatest dimension, 5 centimeters. In 5 centimeters, the greatest dimension of the lesion, the pathologists only find a few area of malignant cartilage formation, and based off this area, the diagnosis of mesenchymal chondrosarcoma has been reported for the patient. And you see here IHC study of the whole excited lesion that CD99 confirmed as a incisional biopsy, strongly positive in tumoral cells, but S100 positive in some tumoral cells with cartilage differentiation. And as you see, if you remember, this picture is S100 for incisional biopsy. And as you see here, we face to some scattered positive immunoreaction cells for S100, not beside the cells with cartilage differentiation or with calcified structures. Between the all tumoral cells, few scattered cells demonstrate positive immunoreaction for S100, but in the excited lesion, positive cells for S100 be in the cells with cartilage differentiation. And finally, based on this IHC result and also histomorphologic study, for excited lesion, diagnosis of mesenchymal chondrosarcoma was reported. And you see here the custom-made construction plate for the patient. And you see here custom-made construction plates. As a take-home message for the case number 3, I would like to mention this point that in mesenchymal chondrosarcoma, it's very important to taking and using several subsectioning to find some area of calcified material. In most of mesenchymal chondrosarcoma, abundant area of the chondroid material has been found, but in some occasional cases, like our cases in number 3 case, maybe tumor has a scarce area of cartilage formation. And it's very important to take numerous sections for discovery of this area, this scarce area of chondroid formation. And also, as you see, the nest or area of cartilage formation in the maybe usually in the most cases resemble normal cartilage, and also maybe have a mimicking low-grade chondrosarcoma in some cases. It's not very different. Only discovery this area of cartilage formation is very necessary to diagnosis of mesenchymal chondrosarcoma. And in the last point is the interface between the area of chondroid formation and the tumoral cells. Maybe in more cases was quite sharp, but maybe it was very melting in each others in occasional cases. And also for the last take-home message for these cases, as you see, I mentioned in the histopathologic view of the lesion, I mentioned the uniform pattern of the tumoral cells without significant polymorphism, and these views resemble the cell of Ewing sarcoma. As you know, both Ewing sarcoma and mesenchymal chondrosarcoma demonstrate positive immune reaction for CD99, and it's very important that IHC can help us, but after more and more histomorphologic evaluation and after several subsectioning, IHC can help us. But in the first line, the IHC study can misguide us and make to miss the definitive diagnosis of the lesion. It's very important that Ewing sarcoma or Prinet family is the most and the first level of differential diagnosis with mesenchymal chondrosarcoma. And all of these tumors are infrequent in head and neck region, but it's very necessary to differentiate between them, and subserial sectioning can be help us after the finding or discovery the area of chondroid material. Even this area was very small or based on the textbook, very scarce. And I would like to say special thanks to Dr. Abbas Karimi for invaluable helping and collaboration, great collaboration and data gathering for the case number 1 and also for case number 3. And finally, I'm here for any question. I really wish my presentation be informative and interesting for all of you, and my warm regards dedicated to all of you. Dr. Shakib.
Thank you, Dr. Derakhshan, for your great presentation and interesting, challenging cases, and also well-documented cases, including all the radiographic and also clinical manifestation of challenging cases. I think we have about 5 minutes to have discussion on these 3 cases. And let me get started with the first question. And you explained about the last case, about how did you interpret CD99 positivity for the malignant tumoral cells. But would you please re-explain for us how do you interpret CD99 positivity of the tumoral cells for mesenchymal chondrosarcoma, because we commonly expect that CD99 positivity are is associated with Ewing sarcoma. How do you interpret this positivity for a mesenchymal chondrosarcoma?
Thank you, Dr. Shakib, for your good and nice comment. For evaluation of CD99, based on the all evaluation and all the data I received from my professors in our department and also in professors in hospital, I reached to this fact that it's a wrong fact for concepting this concept that CD99 is only belong to Ewing sarcoma or penis family tumors. It's a wrong fact, and it's very necessary to mention that CD99 is not spatially for only Ewing sarcoma, and many other sarcoma can show positive immunoreaction for CD99. The first level of this list is lymphoblastic lymphoma. If I'm right, lymphoblastic lymphoma maybe showed us the positive immunoreaction for CD99, and also mesenchymal chondrosarcoma and also monophasic synovial sarcoma can also show us the positive immunoreaction for CD99. There is two important points. One is the membranous pattern of the positivity is very important. Nuclear positive for CD19 is not acceptable for us, and only membranous pattern is very important and acceptable for us. And also we should be exclude all of the other tumors with immunopositive immunoreaction for CD99. And finally, we choose and diagnosis of Ewing sarcoma. And also another histomorphologic feature of Ewing sarcoma, like adenoid or rosette-like pattern in Ewing sarcoma, and also spatial pattern of necrosis, like geographic pattern of necrosis in Ewing sarcoma, is very important for us to diagnose the Ewing sarcoma. But lymphoblastic lymphoma, based on the different in treatment, is very important for the surgeon to exclude by the pathologist. And also in the case number 3, you see the LCA was negative in tumoral cells, and also for monophasic synovial sarcoma, EMA was negative in tumoral cells. Also I know that BCL2 and also TLF4, if I'm right, TLF4 is very more important rather than the EMA in diagnosis of monophasic synovial sarcoma. And finally, in this case, the finding and discovery of a fossa of chondroid material in evaluation of whole excited lesion can help the pathologist, the hospital-based pathologist, to make a definitive diagnosis of the lesion we reported in the incisional biopsy as only infiltrative small round cell sarcoma without any differentiation of the tumoral cells.
Great, thank you. I can conclude your comments as that we are supposed to interpret IHC study as a panel, as several biomarkers, and it is very challenging to have an appropriate interpretation of IHC study of a case, of a challenging case. Okay, thank you very much. Because of time shortage, we are going to wrap out this webinar at the moment, and let's go to the last part. Dr. Prabhu, are you with us? Okay.
Yes, doctor. Yeah.
I would like to invite all participants to turn on their webcam for the last group photo. And I would like to ask Zohre, are you with us? Would you share the, okay, great. At the end of this webinar, I would like to express my sincere appreciation to Dr. Prabhu for joining us in this webinar, and also I will send it to you, Dr. Prabhu, via email. Thank you for joining us, and I'm sure you will stay with us in upcoming webinar and also programs. Thank you. And
it's a privilege and honor, and thanks a lot, Dr. Shakib and Tehran University of Medical Sciences. Wonderful opportunity, and I got to learn from your side also, amazing cases from your side and beautiful histopathological images. I got to learn a lot today from your side. Thank you.
You're welcome. And the next one, I would like to thank Dr. Derakhshan for presenting such a great and well-documented cases in this program, and she will also, I'm sure she will help us in upcoming webinar and also programs. And at the end, I would like to thank all the participants for being with us during this webinar. And I'm glad to let you know we are about to arrange the second journal club with Professor Alena Skalova in late February. And I'm sure it is about to arrange some details, and I'm sure it will be very great to have a short review of how we can report salivary gland carcinomas. And I hope to meet you soon again in about 2 months later. Thank you very much and have a nice day. Bye-bye.
Thank you. Thank you. Thanks a lot. Thank you.
Have a nice day.